Catherine Whelan is in private practice in Annapolis, Maryland. Catherine holds a Bachelor of Science in Kinesiology from the University of Wisconsin-Madison. She has been working as a body worker for almost 20 years. Catherine has been training with the Upledger Institute for 12 of those years. Catherine is a certified CranioSacral Therapy 1 instructor with the Upledger Institute and is beginning her apprenticeship to teach UI's Listening to the Second Brain, the Enteric Nervous System class. So with that, I am going to stop my share and I'm going to say thank you so much, Catherine, for being with us here today and presenting.
Thank you, Justin. So I'll start my share. So go here. Great, so thanks, Justin, for this, and thank you to all of the participants that are here from all over the place. I'm coming from Annapolis, Maryland, from the East Coast tonight, so it's in the evening here. And I'd love to thank the Upledger Institute and the fact that we're doing these In Touch series. So they've really been really great. Tonight we're going to be here and we're going to be talking about deconstructing chronic persistent low back pain. So this is a problem that affects a lot of people, as we probably all have encountered. They find that this is the #1 reason for disabilities or days missed from work worldwide. So the #1 reason is chronic low back pain. In the US, it's about $600 billion spent annually on treating chronic low back pain. So that would be direct medical costs, but it would also be indirect costs of loss of wages and different things. So $600 billion annual, which is a huge amount. It's more than heart disease, diabetes, and cancer combined. So it's a very big amount. So we're going to talk about, we can see how it's an important topic, and we can see that that people here probably have been affected by low back pain. We're going to talk a little bit about that. And so let's see here. Forward. Okay, sorry. So we're going to discuss about chronic low back pain. We're going to discuss who gets it, what causes it, and we're going to go over some of the anatomy. So we're going to kind of take a little bit of an interactive tour of the anatomy and the different systems involved with chronic low back pain. And then we're going to cover how craniosacral therapy can help. So we're going to talk about the listening skills that you learn in craniosacral to be able to listen to the whole system, not just to the pain story. So we're going to listen to the whole system and how craniosacral therapy might help. We're also going to talk about how that system of the low back and the sacrum and the pelvis and the dural tube is affected, and what happens to the occiput and the corresponding parts when we have low back pain. So what happens? And then we're going to finish tonight with some movement exploration. So we're going to do a little bit of a movement. So I'm going to ask all of you tonight to move if you have the ability to. If you don't, it's okay. You can do a visualization. And as Justin said, this is available on Facebook. It'll be available to watch later. So you can always come back and do it. And I'll have a handout that you can access afterwards to cover the movement pieces that we're going to cover also. So you'll be able to have that. So we're going to start talking about chronic low back pain. So we had thought about, I wanted to have a poll here. So I wanted to take everybody's, ask a question about how many people here have had low back pain. So we'll see if Justin, if we can put that poll up or not.
Absolutely. And thank you for having me. This is the first time during an In Touch segment I've done a poll. So thank you. Let's see here. The first question you wanted was, what is your reason for attending tonight? Is that correct, Catherine?
Actually, let's do the first question as how many people have had low back pain?
Oh, I got it. Sorry. There we go.
No problem. So look at that. We have 91% in the 90s. Wow. So it looks like 88% is what I'm seeing. So that is quite a number. So 88% coming in. That they show that with chronic low back pain, that most everybody will encounter it at some point, or not chronic, but low back pain at some point in their life. So probably on the high end, it was saying about 70%. So we have 88%. So I'll share those results, 88% having that. So I think that's a big number. And then we wanted to do a second poll, and the second poll that we're going to have is to have Justin share why you're here tonight. If you're here for your own low back pain, maybe for clients or family members, or both. So if you guys don't mind doing that, we'll see where we're at. Good. Yeah, so we have mostly both, and to help others. So like true manual therapists, we only have 2% that wants to help themselves, but most people want to help others. So thank you very much for those shares and those polls. That gives me some good information. So, okay. And we're moving right along. So is the poll still up, or is it down?
I believe I can pull it back up. You want me to share the results, Catherine?
Yeah, I think, did they get to see their, let's see.
Oh, I'm sorry. Oh, there we go. I'm sorry. I had selected it. It should be up now.
Okay, so yeah, 2% with who are just trying to treat their own back pain, but wanting to help others, or both. So I think that is a nice cover here we have. So, okay, so now we're going to go on to the slides. So, and I'm just wondering, Justin, is the poll down now? Can you just see my slide?
Yep, we're just on your slide. I ended the poll. So
okay, for some reason I can still see it on my screen.
Okay, will it allow you to?
Let's see. Stop sharing. It will not, but that's okay. We'll kind of go through. We'll see if it changes for me on the next slide. No, it stays up. Do you mind if I come out for just a second and stop my share?
That is no problem at all, Catherine.
Okay.
Is it still on the screen for you?
It was, but now it's not. So share screen. Okay.
Cool.
Thanks. Okay, so who gets chronic low back pain? So as I was doing my research, it was interesting. There were some people that I was noticing in the research articles, and it was saying that women oftentimes have more low back pain than men, which I thought was kind of interesting, because I think that I didn't expect that. I expected, we hear about men with manual labor, that maybe they often have more low back pain than women. And that there's a particular industry, 2 industries actually, that tend to get the most low back pain. And that would be the aerospace industry and the defense industry. So those are the highest populations of back pain, which I thought was quite interesting also. But what we know from the pain science and from the chronic low back pain piece is that it's not just one thing. So here we have the picture of my stick figure who has bent over to pick up their shoe and their back hurts. Well, maybe that back pain is not coming necessarily from just that one time of picking up the shoes, but maybe it's coming from, maybe they go to their job, and every day that they go to their job, they're unhappy. And so they were putting on their shoes to go to work, and it was triggered the low back pain. So they find that there can be psychological pieces, there can be physiological pieces and sociological pieces that contribute to low back pain. So we're all pretty individual in why that low back pain might start. And that if we are under stress, that can really make the pain worse. Stress or emotional, whether that's anxiety or depression, can also make it worse. And then here we have the person who is out on vacation, flying a kite, and there's no low back pain in this situation. And so I was talking to my dad about pain and how he was talking about, isn't it funny that your pain is always there when you're going to work or when things are hard, but as soon as you're out doing what you enjoy to do, you start to forget about all the pain. So what might cause low back pain? What are the different causes that we might see when we have clients come in who have chronic low back pain? So I'm going to put up the list here. This is not the extensive list, right? This is a long list, but there's more reasons. And I have this list, and we're not going to go through all of the pieces because they're actually not as important as why it's coming from as just knowing that each person is individual. So each person that we're working with really has an individual makeup of their story and how they might have come along with the low back pain. When Justin asked me months ago to do this talk, he thought maybe there was a case study that I did about working with a man in his 40s who had chronic low back pain, and we had some real success about it. And he said, maybe you could talk about that case study. And while it was a really interesting case study, and it was wonderful because it was successful that his low back pain went away, I thought, is it interesting enough to be able to talk about for an hour? And for him, when he came in, it was just run-of-the-mill low back pain. He had played a lot of sports growing up, and he had had the pain for a while. And as he went along, we were starting to work, and all of a sudden, some of the emotional pieces started to come up in the session. And we found out that at the age of 4, he was hit by a car. And so he was hit by a car at the age of 4. He did okay. It was pretty minor for being hit by a car at the age of 4, but the emotional storage in his system and in his tissue, when he started to make those connections, and that's what he did during those CranioSacral somato-emotional release sessions, that's what really was able to help him to resolve the low back pain, among some other pieces that we'll talk about too. So those are some of the parts of why we might have it, but we also know that chronic pain doesn't have just one thing that it comes from. It's multifaceted. It never just comes from, going to pick up your shoe or just one piece. Even though if people may equate it to that one piece, there's always something else that's been going on. So chronic pain is defined as anything that lasts longer than 3 months. So if you've been in pain for longer than 3 months, it's considered chronic pain. It often occurs when there's inadequate treatment of the acute pain. And while that's either somebody maybe ignoring their pain for a long time and not getting treated, or maybe they're seeing somebody who's not treating the pain in the way or the problem in the way. That's why I also really appreciate CranioSacral therapy, because it's so wonderful in the preventative way that if somebody's coming in and maybe they just slipped on ice and you're doing a session right away afterwards, it's going to help prevent it from becoming chronic. If there's nervous system changes, so maybe this person is in a sympathetic, hyper-aroused sympathetic state, so they're in that fight or flight state. And if they're in that fight or flight state, it's going to be much more likely to have pain. So anytime we're kind of in that stressed out state where our sympathetic nervous system is always on edge, it's more likely to be able to have pain. Justin's going to talk about this later, but we really have a wonderful opportunity coming up with Beyond the Dura in a couple of weeks here in April, where Stephen Porges is going to talk about polyvagal theory. And so we're going to talk about polyvagal theory and helping the nervous system to regulate a little bit. And I believe Avedon Larson is going to also talk about that. So talking about those nervous system changes and how that can make a difference in how our body perceives pain and holds on to pain and maybe even identifies with the pain. The psychological factors. So this is the piece of, it's kind of the chicken or the egg. to know whether or not maybe the person was depressed or had anxiety first and then the pain came on, or maybe the pain was there and then that brought on the depression. One of my first jobs was working in a chronic pain clinic in Colorado. And one of my very first patients was a woman with chronic pain, chronic low back pain. And I was seeing her and she was just always very grumpy, kind of rude, or just very, curt in any of our sessions. And I thought, does she not like me? What's happening here? And so we'd go about and we'd do all this work and help her out. And then after a number of weeks, she started to improve and her back pain started to decrease. And all of a sudden, she was the most pleasant person that I had ever worked with. And I realized at that moment, it was so early on in my career as a body worker, but I realized at that moment how important it is to watch the personality of somebody when they're in pain. If you don't feel good, you maybe don't feel like being nice to everybody and having the pleasantries that you do when you're out of pain. So I really realized at that moment that her demeanor out in the world was because of her pain and not because that's just who she was as a person. Inactivity is also a way that pain becomes chronic. So pain for us is one of those things that helps to protect us. So pain is something that gets sent from our body into our brain to say, or the signal gets sent to our brain and our brain says, oh, this is dangerous. We better create a pain signal so that the person doesn't do it. So the brain sends the signal to say, oh, this is dangerous, don't do it, and create some pain. And so if we have that happen over and over again, if it becomes chronic, then all of a sudden we're going to start to limit the movement that we do. So now something that we did before where we'd bend over and pick something up, now we're going to be a little bit afraid that we're going to bend over and it's going to create pain. So we're not going to bend over as much, or we're not going to squat down or twist. And so we start to do less movement because that pain has now become overprotective. So it's like the overprotective parent that we're working with, where the overprotective parent doesn't want their kid to do anything or go outside because something might happen. And that's the same thing. So our body starts to think that anything's going to cause pain, when in actuality, motion is lotion. The movement is important. And that's when we come at the end of our talk tonight. We're going to talk about how that movement is so important and finding safe movements to be able to do that don't cause pain will start to get us out of that pain. And then also any underlying health conditions that a person might have might create some more of that chronic pain. So next we're going to go through our anatomy, our interactive tour of the systems. So we're going to go through the anatomy pieces. What I'd like for you to do is follow along by palpating with your hands. So go ahead and place your hands on the areas, kind of feel. And if you can, when you're placing your hands on your hips and your low back, if you can do it from a mindset of listening with your hands instead of just from doing. So often as manual therapists, we try and do instead of listen. And we just want to listen. What is our body telling us through our hands? Or what is our client's bodies telling us through our hands? So here we have the skeletal system that we're looking at first. And here's just a reminder that we're going to place our hands onto these areas to be able to feel the areas, to feel what they feel like through our hands, but also just to connect in a different way, in that listening way. So if we look on the left-hand side of the screen, we're seeing the whole spinal vertebrae. And so we have the first lumbar vertebrae right here, first, second, third, fourth, and fifth. And then the sacrum and the coccyx. So if you can, you'd find your first vertebrae, first lumbar vertebrae, just at the base of the ribs. So you can see in this picture, here's T12, here's the rib, the 12th rib, and then we have L1, 2, 3, 4, and 5 before the coccyx. So when we see this on this side, notice how that lumbar has a curve, kind of a C curve, and that mimics the C curve that we see in the cervical spine. just the same as the thoracic curve kind of goes the other direction, as does the sacrum. And so this is something called the law of spinal correspondence, which means that if one of these areas starts to get a little off, we saw in that list maybe the lordosis or the kyphosis, that the rest of the spinal column is going to start to correspond with that. So it's going to start to change and shift. So if we're always in that forward head posture, that's going to affect our low back. Or if we have a real big posterior pelvic tilt or a real big anterior pelvic tilt, that's going to affect our neck. We're going to see when we get down into the dural tube, how the dural tube corresponds then from the sacrum all the way up to the occiput. So then in this picture here, we're looking at this area. So this is our low back region that we're working with tonight. We've already talked about that lumbar spine. And then we have an ilium on either side. Here's our sacroiliac joints. So we can see the sacroiliac joints or the SI joints. This is often one of the problems with low back pain. Those joints can kind of get out of place a little bit. We have the pubic bone and the pubic symphysis and our ischial tuberosities, our sit bones. You can see in this picture, and we'll see better in a future picture, the acetabulum or the hip socket. So we have the hip socket here. And then we're looking at a posterior view here. So we have an ilium on one side, ilium on the other side, sacrum right in the middle, and the spine above. So ischial tuberosities, our sit bones. So here, look, this is the head of the femur. So we have the head of the femur right here, and that goes right into that acetabulum of the ischium. Okay. And this, we're looking at skeletal here, but now we have some of the ligaments in place, and just gain an appreciation for the ligaments of the spine. So we can see the ligaments around the lumbar spine and how they connect into the iliums. You can see here our inguinal ligament. So go ahead and feel your inguinal ligament right across that front of the hip. Sometimes those inguinal ligaments can be kind of tight on one side. And then we have our posterior view. So our sacrotuberous ligament, the Y-shaped ligament, the ligaments that connect the sacrum and the coccyx. So this might encourage you also, as you're doing your palpation and your listening of your own body, that maybe you're going to pull out an anatomy book and remember some of these pieces going forward as you start working with some of this information. Here, looking at the hip joint, so we're looking at the ligaments around the head of the femur that connect in and kind of hold our hip in place. When we do the movements, we're going to be doing two movements, one where we're going to internally and externally rotate the femur. And so thinking about what are those ligaments doing, not only the muscles, but what are the ligaments doing during that piece? And then one where we're going to compress the femur into the hip socket and then decompress or distract the hips out. So, and you can see here, that's the acetabulum. So that's where that head of the femur goes. Here's our piriformis, which can often cause problems also. Okay, and so now here we're looking at the lumbar vertebrae. We can see the body of the vertebrae on the left-hand side, and then the spinous process here in the back, and the transverse process, we can just see one side. So we're just seeing them separated, quite big vertebrae. And then on this side of the screen, we're looking at the discs. So we're looking at the discs that create a little bit of space in between the vertebrae. And we're seeing here that that disc is a little bit of a protrusion into L4. So into the nerve root going out from the lumbar 4. And we can see that, you know, herniated disc or a little protrusion. Here we're seeing that protrusion happening into the cauda equina. So we can know that disc problems, lots of people with disc problems, lots of times where there's surgical interventions, pain medication, different pieces that people have, and that this work can be very helpful for them. So we're looking at the central nervous system here. So we've moved the spinous processes from this side of the picture, And you're looking, here's the spinal cord. So the spinal cord itself, which ends around L1 or L2. So it ends right here at the conus medullaris. This is the cauda equina, or the horse's tail coming off. And you can see the filum terminale, the connective tissue that holds that spinal cord down, and it blends in with the S2 of the sacrum and then down through the coccyx. So it's actually, I did the dissection class with Upledger, and we did this dissection where we removed the back part of the sacrum, right, like this, just that little bit, and you could see that filum terminale. It was really neat to see how fine it was and how anchored in it was. And then on the right side of the screen, we're looking at the craniosacral system. So we have the cranium here, the dural tube, the sacrum at the bottom. And so that dural tube is the connection between the dural membrane, so all around the cranium. We have our foramen magnum, which is one of the osseous attachments. It also has osseous attachments at C2 and C3. And then that dural tube all the way down to the sacrum, where it has the osseous attachment at S2. So as we're working, what we want to notice in this picture is that notice how these nerve roots that come off in the cervical and the thoracic spine come off a little bit more horizontal. And then we see these that they're coming off a little bit more longitudinally, and they tend to be bigger nerve roots in the lumbar spine. And so these bigger nerve roots sometimes have a bigger pull if there's tension. So if there's tension into the sacrum, that can have a bigger pull on the dural tube. And since we have this osseous attachment at S2 and at the cervical spine, that oftentimes if the sacrum is out of place, if it's maybe off a little bit or pulled down, or if there's, the leg length discrepancy, that can affect where it's attached at C2 and C3 and the foramen magnum. So all of these pieces play into how low back pain creates problems, not only for the pelvis and the low back and the legs, but can go all the way up the chain into the neck and into our cranium. Here is a great picture that I love. So now we're looking at the viscera. So we're looking at, if you look here, this is an ileum on the right-hand side, and we can see the small intestine and the large intestine in there. We can see the liver, so we can see how tightly packed the viscera, the organs are in the skeletal structure. It also is showing all the nerves that are kind of coming off and through, and some of the blood supply. So I think it's a pretty interesting picture. One of my loves of this work is the enteric nervous system, which is, as Justin said, I'm going to start my apprenticeship with Nikki Kenward in this class. And what I've realized is that there can be, sometimes our pain can arise because there's problems with the organs. And especially because the small intestine is encased with the organ, the mesentery, which provides the blood supply and the nerve supply to it. And that mesentery attaches to the posterior abdominal wall at L2. So what do you think that if there's a little bit of tension in that attachment at L2, it can create a tension pattern all the way into that lower lumbar. Whenever there's an issue with the organ, sometimes it can create a muscle spasm nearby. So sometimes our QL or the low back muscles can kind of spasm if there's problems with the organs. Oftentimes, if people suffer from constipation, they'll notice that when they're more constipated, they'll maybe have more left side hip pain or left side low back pain until they maybe have a bowel movement. Going into the muscles. So we're looking at the muscles here. We have the muscles of the posterior wall. I want you to notice the diaphragm, so our breathing diaphragm right here, and notice the legs of the diaphragm or the crura of the diaphragm. They come down and attach in around L2. And then if we look here, these are psoas major and minor on either side. So psoas major and minor are major hip flexors of our body. and they attach higher. So they attach into T12, L1. So they even attach higher than the diaphragm. So sometimes our breathing can affect our low back. Oftentimes when we're in pain, we don't breathe as much. We shorten our breath. We avoid the pain in that way. So the breathing can change with the pain also. Here we can see the psoas, and then just behind it is the quadratus lumborum, or the QL muscle. And sometimes the psoas and the QL can kind of become adhesed together. I see this oftentimes in the spring of the year when people are gardening or doing more yard work and they've been bent over all day, and then they go to stand up and they have a back spasm. And sometimes that's just coming from the psoas, that deep hip flexor. We're looking at the side view here, so we can see that diaphragm. Here's our transverse abdominis, part of our core muscles, and looking kind of into the pelvic bowl. Back to our skeletal system on the left-hand side, and we're seeing the nerves. So we're seeing the lumbar plexus and the sacral plexus in green, and we kind of see how they flow right through. We have the sciatic nerve in the back, our femoral nerve in the front, and then we have over on this side, we have the psoas major and the psoas minor iliacus, and how they attach into the top of that femur. And then here we're looking at those psoas major and the iliacus, and then the QL. So looking at that close relationship between the two. Here we have the rectus abdominis muscle, part of our core also. So some of the pieces. Looking at the back, the posterior view, so our back body. So looking at some of the intrinsic muscles of the spine. Here's our transverse abdominis. There's that QL. Here we have the longissimus. So all the way up from that occiput, we have that connection between the occiput and the sacrum, all the way down into the sacrum. Here we're starting to see the gluteus muscles, or the glute max and the glute med. We're going to see that in the next slide. So here we have a glute max on this side. So that attaches into the sacrum and then into the IT band, you can see here. The glute max extends the leg, so it's going to have an extension piece of it. And then just above it is the glute medius. And so here the glute max has been removed, and we have the glute medius, which attaches into the iliac crest and then onto the greater trochanter. The glute medius and the glute minimus, which also same attachments, just a little bit lower. Both of these muscles are stabilizers of the pelvis and the hip, and what they do is they stabilize the movement for walking. So they stabilize our pelvis for walking. And so as we walk, it doesn't allow the other hip to drop. So we keep that stabilization. In the research, it really shows that if our glute med or glute medius is weak, that then there's more of a chance for having low back pain. So it's important to keep the strength in the gluteal muscles, and that'll be the last exercise we do today, is trying to see if we can engage all three of these muscles. And so when we engage the glute max, most people will feel that, and it'll be nice and easy. But it might be a little bit more difficult to engage the glute med and min, especially if they haven't been firing as much. So we're going to try and focus on being able to get all three engaged on both sides. Okay, so we're going on to how craniosacral therapy can help. So when I first started at that clinic working with chronic low back pain, I had just got out of school. I had done my kinesiology training in college and then went to massage school. And most of my training had really focused on pathology. So it had focused on what were the problems, what were the symptoms, what was the pain story. And so when I started working with people, that's really what I looked for. I looked for how to treat, how to fix people. And so I was really looking at what are things that I can do that's going to make this person better. And then after working for a number of years, I finally decided to take my first CranioSacral class. And my first CranioSacral class I took in Colorado with Dick Larson. And this was the first time in all of my education that I heard about the body being self-healing, that the body has the ability to heal. And if given all the resources, it can do that on its own. And just like anytime we get a paper cut, the body heals that. So knowing that we can heal ourselves. And I had never heard that before, right? Everybody had always talked about what the problem was and kind of what we do to fix it, and looking very of a reductionist view, or looking very specifically at what we were working with problem-wise, but not looking maybe nearly as holistically. And so when Dick said this, that the body is self-healing, it really was a missing piece for me. It really made me realize that it awoke something in my brain, but it also made me had a resonance with my body to notice that this work is so important, and that when we start to orient to the clients that we work with, to the health of their tissue and support the healthy parts, that allows them to be able to do the work. So I, retired from fixing people and became more of the, as Marianne Cisco says, the inner physician assistant. So I started to listen more. And that's one of the skills that I think for anybody taking craniosacral work is so important, is the listening that comes from our hands. So before we start to do anything, we just place our hands on, we blend and meld, and we just listen to what the tissue is doing. So that was a big missing piece for me. And it changed how I worked with these patients with chronic low back pain, because a lot of them got better and they did really well from the, more direct medical kind of treatment style work. But there were a number of them who I thought, oh, they should be getting better, but they're not. What else is going on? And so this listening, this changing my focus to listening to the whole person. So we listen first, we listen with our hands, we place our hands on and just be able to listen. And that includes listening to their whole story, listening to the body's whole story. Remember, I talked about my case study, how I would have never have known that he had been hit by a car until we created such a safe environment that he was able to, oh yeah, I remember that this happened when I was 4 years old. And this is how my family responded. And it was pretty scary. So we treat the whole person. We don't treat the diagnosis. That's why that list of all those different things, we don't have to, know how to work with all those if we really listen and tune in with the person and helping to the person to be able to listen to their own body. Also asking about their stress level. So I grew up in the Midwest and lived in Colorado for a long time, in Montana. And then I moved to the East Coast, and I moved just outside of Washington, D.C. And I had never experienced clients under the same amount of stress that I do living in this area. And so I realized, I would ask people, oh, how's your stress level? And they would say, oh, it's not bad. It's no problem. And I said, oh, okay, what does your normal day look like? And they would say, oh, well, I commute into DC and it's about an hour and a half each way in really heavy traffic, some of the most horrible traffic. And then, I work a grueling job, possibly with the government or aerospace or the Department of Defense. And then I drive back home an hour and a half and then try and spend time with my family. Which doesn't really leave much time for movement or self-care. And so stress level is really important. And this comes back to that idea of beyond the dura when we talk about beyond the dura. Craniosacral therapy can be really good at prevention. We already said this earlier, where we talked about how prevention of creating chronic low back pain. So just starting to do this before we get to the chronic level. That parasympathetic. So when we have a craniosacral session, we go into that parasympathetic state. So Stephen Porges, Avedon Larson, I'm sure a lot of people are going to talk more about that parasympathetic state at Beyond the Dura 2023. And then we also want to just be aware of any emotional factors that might be involved. So that's the somato-emotional release pieces. So we have the dural tube, and thinking about that dural tube, how it's all the way connected down into the sacral segment. So that second sacral segment. And so we can have reciprocal tension that can go up into the occiput at that foramen magnum and affect the dural membrane around the brain, and all the way down, and how the spinal nerve roots can kind of pull onto it. So doing the sacral techniques that we learn in Cranial 1, if you've taken Cranial 1, is releasing that L5 from the sacrum. So stabilizing L5 and tractioning the sacrum away from it, and then also helping the body to release those SI joints on either side. And then occipital cranial base, because maybe it's coming from something that's, that forward head posture that they're in all day at the computer. And so maybe that's having an effect on their low back. I know that preparing for this, doing my slides and all the research, that my low back was more sore the days that I was more sedentary. So habits that I've seen in clients that have had success, some of those habits. So being curious about the sensation. So kind of going into the sensation and clarifying what it felt like. So maybe not talking as much about what the pain is, but noticing just the different sensations that they might feel and going in towards them, maybe using breathing techniques. Really empowering our clients. So having them be self-empowered. So for them to be able to listen to their bodies in the same way that we be able to listen to our bodies. And so that includes having compassion. Oftentimes when we're in pain, there can be a little bit of anger towards the pain or anger towards the limitations. So finding compassion for our body as wherever it is and for how long it needs to heal. I find that people who have daily movement with that listening mindset tend to do better. So somebody who, whether that's a daily yoga routine, walking, stretching, any of those things, daily movement, it allows them to know where they're at each day and adjust accordingly. And then strengthening when appropriate. So strengthening the glutes and the core can really help to stabilize that low back. And so then we're going to go into the movement exploration. So we have about 10 minutes left here, and we'll take the rest of the time for this movement. So if you get comfortable, you can go ahead and find a place to lay down, or even just stretching out your legs if you need to. And remembering that this will be on a handout available to you at the end. There'll be a link for that handout. So we want to find a safe position. So we want to find a position that doesn't create pain. So you can put a pillow under your knees if you need to, whatever it is, to be able to be comfortable. And we want painless movement. So I'm going to cue you to be able to do that painless movement by making it smaller if it creates pain. So we don't want to trigger the pain. So we might just want to make it smaller. Or if it doesn't work to make it smaller because you still have the pain, then you're just going to visualize the movement. So visualizing the movement, now we find that visualizing can increase strength, it can increase the neural patterns. So just visualizing the movement if you can't do it without pain, or if you can't move in a place right now that you just want to be able to visualize it happening. I'd like you to focus on quality of movement over quantity. So I don't care how big the range of motion is. I'd rather have the range of motion be smaller, but the movement be smoother and easier. So quality. These are easy exercises to implement in your daily life. You can do them before you get out of bed in the morning or when you go to bed at night. It doesn't have to take some real long time. You can also use the still point inducer or the sacral wedgie during the exercises possibly, or after the exercises if you want to. So having that can be self-care also. So the three movements that we're going to go through is the wipers. And the wiper movement is going to be internal and external hip rotation. We'll see that in a moment. And the reason that I've chosen these three movements is that they help to isolate the different areas. So we're in a safe position. We're not asking our body to do too much. And we just want to be able to isolate, can the femurs move internally and externally without involving the low back? And then we're going to do a heel reach. And so can we compress and decompress the hip socket without involving the low back? See a trend? And then we're going to do the glute squeezes at the end. And so can we engage our glutes without engaging too many other things? Okay, so hopefully everybody's found a comfortable place. We're going to be laying on our backs. Again, you can have a pillow under your knees. And so you're going to kind of pull your toes back and point them towards the ceiling. And as you do that, making sure that you are not doing it in a way that it's creating tension in the body. So just a little bit of pulling those toes back. They don't have to be all the way up. So pull the toes back. And then we're going to begin by rotating. So we can internally rotate the legs. And so my arms are going to be my legs in this position. And so we're going to internally rotate and our toes are going to point towards each other. And as we do that, we're not going to involve the low back. And this movement doesn't come from the ankles. So it doesn't come from the ankles like that, but it's going to come from the hips. So it's going to come from the socket of the hips. So the legs are going to follow in. So we internally rotate and then we follow by externally rotating. So now we're going to take the toes out. And so just going back and forth in between that internal and external rotation. So just taking your time, remember quality of movement over the quantity of movement. So your range of motion doesn't have to be very big. You're just going to rotate in as far as you can without any pain, and then externally rotate as far as you can without any pain, and see, are they smooth? Do both sides come in equally? Is one side a little more ratchety? Just noticing what you feel. And notice, is the low back getting involved? So is your pelvis starting to rotate? Are your hips starting to rotate? What's happening? Okay, so that's the wipers. And then the heel reach, same start position. So you can let your body come to a relaxed position. And you're going to begin by reaching one heel away from your hip. So it's a very small movement and it's right at the hips. So it's just below the hip pointers. If you place your fingers or the hip bones, if you place your fingers on the hip bones, it's just below that. And so you're just going to reach one leg long. And as you do it, you're going to bring the other leg in towards the hip socket. So that other leg's going to come in and then you're going to alternate. So it's as if you're reaching the sole of your foot to touch the wall and then go the other way. So it's just back and forth in that motion, reaching one leg long and then the other leg long. And what you'll notice probably is that it's easier for one leg to go further and it's easier for one leg to come in. So usually one hip compresses better and one hip decompresses better. And we just want to smooth that out to see if we can find it to be equal on both sides. We can find a little bit of that equal movement. And again, we want to avoid involving the low back. So we want to avoid where the pelvis is going to tilt or we're going to hike up that hip or the QLs. So we want to just make it small enough that we're not going to involve the low back in this movement. We're just trying to isolate what's happening at the hip socket itself. You can also do this exercise with your knees bent, where you would just reach your knee long instead of reaching your heel long. And that can help. So that's sometimes known as walking knees. So after you did the wipe or the heel reach, let's go back to doing the wipers. So you're just going to go back and you're going to go internally and externally rotate, and just for a few rounds, and see if you notice a difference. See if the movement's smoothed out a little bit or not. Good. And then we're going to go to the glute squeeze next. So this is the one where we're going to squeeze all three areas, all three glutes. And so laying on your back, here's our glutes, and we're going to engage both, and we're going to engage both, squeeze them up. only about 70–80% of max, and then release. So slowly release and then squeeze. So you're going to go back to squeezing both. We'll do just a few where we squeeze and release and squeeze and release. If your pelvis is tilting towards your feet when you do it, you're probably using your glute med a little bit more. And if it's tilting towards your head when you do it, you're probably using your glute max a little bit more. So adjusting for that. We can also alternate. So we could just squeeze the right side. And then when you squeeze that right side, hold it there and bring the left up to match it. And then release the left and then release the right. And now this time you'll lead with the left and bring the right up to match it. And then release the right and then release the left. And we'll alternate back and forth. So, and it doesn't, the order doesn't matter. It's just that you're asking your body to do something different. So we're asking that neurofeedback piece of it. So just going back and forth, alternating, and then we'll finish with squeezing both again. So squeeze both at the same time. And what you'll notice is you squeeze both at the same time, that contraction should be a little bit faster and more coordinated and a little stronger. And then let's go back again just to the wipers one more time and see how things have changed. See what you notice. And those are the 3 movements that you can do. Again, I'll have a handout for that. And the handout is available here. And I think Justin's going to put that in the chat. So that covers all of the pieces that we had tonight. So going over chronic low back pain, what kind of the pieces that we can do, how craniosacral therapy helps, and some movements that you can do.